Welcome to Superior HealthPlan's prior authorization education for therapy treatment requests. My name is Heather Albers, and I am a speech language pathologist, working with our participating therapy providers statewide as a clinical provider trainer. The purpose of this presentation is to offer education on Superior HealthPlan's therapy policy for therapy treatment requests. The primary targeted audience includes the requesting occupational therapists, physical therapists, and speech language pathologists. The therapy policy we will review reflects the shared clinical documentation practices of an OT, PT, and SLP. Our clinical reviewers are made up of OTs, PTs, and SLPs with a variety of clinical experiences and specialties in order to best represent the needs of our members. Lastly, with nearly 1.2 million Texas members who hold Superior benefits, we rely on the clinical documentation of the submitting therapists in order to learn more about our members' needs. Therefore, it is essential that therapists include all necessary documentation criteria and tell the story of the patient. A worthwhile notation to make is that the majority of this presentation will refer to the pediatric population, as that is the largest population utilizing therapy services. However, the key points in the policy that will be discussed do still apply to all patient population and ages. Additionally, the slides reviewed in this recording will not necessarily be read aloud each time, so be sure to read the slides as well as listen to the explanations given. Let's get into it and look at the key components our clinical reviewers and medical directors are looking for when we receive your request. Our first step as therapists is to sort out impairments and deficits through our assessment using various methods. Our policy describes this in the following manner: a description of the member's current deficits and their severity level documented using objective data. This can be accomplished through various methods, which the policy states. This may include current standardized assessment scores, age equivalents, percentage of functional delay, criterion reference scores, or other objective information as approximate for the member's condition or impairment. The purpose of requiring this information is for our clinical reviewers to validate the presence of an impairment and its severity. This applies to both initial treatment requests as well as continuation of treatment requests. Regardless if the severity was established 6 months ago, for example, our reviewers must validate the impairments and their severity each and every auth request. In the case of developmental disorders, we assume that the therapy services and ongoing maturation of the member is improving their functional skills and decreasing their severity over time. Therefore, we need to validate where they are each and every treatment request. What is objective? We are trained to make our assessment objective. Objective, in the context of clinical assessment documentation, refers to data that is measurable or comparable to a norm. Documentation contains those observable and measurable data which we obtain through skilled observations, physical examinations, and diagnostic testing. For example, this is what a standardized test does for us, as it uses a norm sample to compare our patient in order to determine how close or far they fall from the mean. Quite often, we receive requests which list the member's strengths and weaknesses, yet do not compare those weaknesses to a norm or an expected ability. Therefore, listing strengths and weaknesses alone does not offer objective documentation. Are those weaknesses 3 years below expected age level or only a 6-month delay? This needs to be clearly documented. The second bullet states that the objective documentation allows the clinical reviewer to validate the severity level. This is important in order to determine how much and how often the patient, our member, can be authorized for treatment. Severity using standardized scores. Let's review a few key points regarding standardized tests. Standardized tests are just one way to determine deficits. However, they are one of many possible clinical assessment tools. Regarding the use of standard deviations, those scores that fall within 1 standard deviation of the mean are considered to be typically developing. Disability is often diagnosed at 1.5 to 2 standard deviations below the mean. Per the TMPPM, which stands for the Texas Medicaid Provider Procedures Manual, eligibility for therapy will be based upon a score that falls 1.5 standard deviations or more below the mean and at least one subtest area of composite score on a norm-referenced standardized test. Therefore, using a 1.5 standard deviation will equal 22 from the mean of 100 or a 78. You can see at the bottom of this slide a 78 representing the ceiling score for mild severity. If a member's test score is less than 1.5 standard deviations below the mean, then additional objective documentation supporting the member's medical need for therapy will be required. An important point to offer here is submitting a standardized test score alone does not necessarily support the request entirely. Be sure to always include functional skill documentation that will specifically support the goals included on the treatment plan. For example, if there is a goal for throwing a ball, yet the documentation only gives the score to the PDMS, then the clinical reviewer cannot validate that this specific skill or function is supported. Always include a functional picture of the member in addition to any testing or scale that offers a score. Severity using other objective information. As stated in the previous slide, the use of standardized tests is one method to determine deficits or disorders. Superior HealthPlan does not require standardized tests in order to objectively make the case for the need for treatment. There are many times where it is not clinically appropriate for a particular patient to complete a standardized test. Either their diagnosis is not part of the norm sample, the test does not account for their cultural or linguistic differences, or it is too soon to repeat the test based on the protocol's instructions. For example, the test was given 3 months ago and the authorization is ending, and it's time to request another authorization for continuation of treatment. Using this same test would omit the reliability and validity components. Therefore, using other means from our clinical tool belt is important in order to assess and document impairments without a standardized test. This slide offers a few ways to do so, and yet is not all-inclusive. For example, you may have a very low-functioning patient who cannot complete many of the probes in a standardized test. Using a method of comparing their functional skill to those developmental expectations of their normally developing peers may be one method to consider using. In this example, a therapist could document the chronological age, including what the expected skills are for that age, and then compare those to the current function and how those skills represent a much younger developmental age. For example, a 4-year-old patient should be doing X, Y, Z functionally. Instead, they're demonstrating skills which reflect a 2-year-old expectation. Therefore, they're functioning 2 years lower than the expected development for a 4-year-old, or they're functioning at half their age. Depending on the entire clinical picture of the child that is documented, this may meet criteria for moderate severity or possibly severe. The main point is that we cannot rely on standardized tests. Rather, we need to rely on the clinical skill of the evaluating clinician in order to be able to validate the impairments and their severity. Frequency and duration of services. The reason objective assessment documentation is important for validating impairments and their severity is that we at Superior need to determine how often and how long therapy can be authorized, also known as frequency and duration of services. As you can see on this slide, for those members who fall into the developmental impairment category, the severity levels are broken into 3 main categories: mild, moderate, and severe. Make note that it is only in the case of mild that therapy is authorized for only 3 months. Both moderate and severe impairments are authorized for a duration of 6 months, with the difference in frequency. Historically, it was only in the case of severe that allowed a 6-month duration. However, this has been a change to the policy in mid-2018, which better serves the member and allows the provider more time to make functional gains with those in the moderate severity category. Frequency and duration for acute injury or illness. As you can see on this slide, acute-based injury or illness has a separate and distinct frequency and duration. Historically, the duration for acute injury and illness allowed for 8 weeks of treatment. However, this has been another change to the policy in mid-2018. The notation at the bottom of the slide reads as, note, as the member's medical need for therapy decreases, it is expected that the therapy frequency will be decreased as well. This applies to all patient populations, not just to acute injuries or illnesses. As our patients improve, the need for therapy typically decreases, and we expect that those requests will reflect this change in severity. Now that we have completed the assessment criteria for clinical documentation, we will take a brief pause to reflect on a concept. It may be beneficial to consider that the assessment is about the member and the treatment plan is about the therapist. Both areas require the expertise and critical thinking skills of a clinician. However, the assessment findings depend on the member's performance and functioning. The treatment plan relies on these same ideas, yet it is within the treatment plan that the clinician can control the goals and modalities to target based on the member's performance. Therefore, reminding clinicians that the treatment plan is in their control shifts onus onto the therapist to take responsibility for that treatment plan, meaning poor progress or poorly written goals are avoidable, as it is within the therapist's scope of practice and is the expectation of that therapist to modify their treatment plan if the member is not making the expected gains. Consider that it may not be the member who is not meeting the goals. Rather, it is the therapist who has not modified the plan to better meet the skill level, rate of progress, or needs of the member. We will circle back to this point in the next few slides. Goal writing. Historically, our prior auth therapy policy included criteria for the treatment plan. However, our clinical reviewers tended to focus more on prioritizing the objective assessment and severity information over the treatment plan. In the past, if the assessment clearly supported impairment and the severity was validated based on the clinical documentation, and the goals were not written well but may have included supported skills and function being targeted, the auth would have been approved. The problem was when the serving therapist would submit for continuation of treatment, they tended to have a hard time showing progress based mostly on the fact that the goals were not written in a manner that they could actually measure their treatment effectively. There would inevitably be a denial based on poor progress or that we, the reviewer, could not determine the progress. This did not help the member, the provider, nor the clinical reviewer. We now prioritize both the objective assessment and treatment plan documentation. Let's review the key points on this slide. All goals are supported by the objective assessment findings. We are looking to see that the functions set within the goals are supported by objective information, specifically supporting they are an identified impairment. For example, if an SLP submits a treatment plan with 10 goals and 5 include feeding and swallowing-based goals, yet the assessment information only describes the language impairments, then those 5 goals are not supported. We do not have objective assessment documentation of those feeding and swallowing deficits through a clinical or bedside swallow evaluation. As always, whenever we are setting goals, we are doing so in collaboration with the client and or their caregiver or parent or spouse, as we need them to be invested in the goals. Setting the goals can be an intervention in itself, as we and the patient and family are looking ahead at the purpose and plan for treatment in an educational therapeutic manner. The second point on this slide states, treatment goals must be functional and written in the SMART format, which stands for specific, measurable, achievable, realistic, and time-based. Let's pause here to discuss a bit more about SMART formatted goals. The AOTA, APTA, and ASHA all discuss the SMART goal format on their websites, yet we see a lot of submissions where the goals are not written in this format. Let me offer a specific example as an SLP. Historically, we have been taught to write the following goal. the patient will tolerate oral motor exercises with 80% accuracy. This is not a SMART nor a functional goal. The word tolerate is not specific. Does that mean endure, participate, or accept in the case of an aversion? The behavior should be specified and not written as tolerate. Oral motor exercises are a treatment modality and not a functional skill to treat. We should be seeing goals set up to measure and target the underlying function. Is the goal trying to achieve labial seal in order to contain oral secretions? If so, then the goal should target that function and the modality should not be part of the goal. Lastly, how does one measure oral motor exercises by accuracy? What is this accuracy being compared to? The measurement should fit the target. Another area is when goals are written with multiple skills and ways of measuring within just one goal. This makes it very challenging for the therapist providing the treatment to measure progress. Therefore, the clinical reviewer will have the same challenge with their review. Keep them simple and focus on one skill at a time. This will only help guide the therapist's treatment more specifically and also allow for easier calculation of progress. One last idea about goal writing pertains to the cues or assist we expect to give our patient. OTs and PTs tend to use shared language via assist levels. Specifically, the FIM, Functional Independence Measure, allows for that shared language to be used and understood across many disciplines by measuring the burden of care or help you are giving that patient. In the area of pediatric developmental disorders, SLPs have adopted this language into our practice, yet have not specified how they define it. ASHA states, cues and prompts be documented as type of cue, utilizing a cueing hierarchy, and frequency of those cues. We need to make sure we are using language and concepts that are supported by our training and practice. The third point on this slide states, goals are written with the intention for them to be achieved during the time period requested. We tend to request treatment which includes goals with very high targets, yet only achieving less than half of that target. Maybe this target is a year away, so write the goal for the target that is achievable. We do not write a goal for, let's say, 80% accuracy and only think they're really going to meet 40%. If that is the case, then we should be setting the goals for the expected achievement level. Making 30% progress towards the last treatment plan is not expected nor acceptable progress when the goals are written to be met. Why weren't they modified if the patient is that far from meeting them? The final point on this slide states, consider a maintenance plan or episodic care when applicable. Maintenance plans can be the next appropriate step and should include goals that are intended for maintenance, primarily focusing on caregiver education and return demonstration. These requested frequencies and durations should reflect that plan. For example, 2 times a month for 2 months, or 3 times a month for the first month, and then 1 time a month thereafter, whatever is clinically appropriate and meets the maintenance plan's needs. Episodic care is becoming more utilized. Many therapy providers are starting to see good outcomes with an initial high intensity frequency over a shorter duration, with a break in treatment and reassessment in the months thereafter for carryover and caregiver opportunity. The policy does not currently support a higher frequency beyond 3 times a week. However, if the clinical documentation supports the request for episodic care and the clinician has clearly designated it to be episodic care, then the request would be sent to the medical director review for further consideration. As you can see, setting the appropriate goals for the client, meeting them where they are with the intention of meeting those goals in order to continue a clinical hierarchy are valued areas for our reviewers at Superior. The evaluation or reevaluation is, at most, 1 hour and 1 visit, yet the treatment plan is for 3 or 6 months. Therefore, we should all be placing value on what we plan to do in a skilled manner moving forward. We're looking to see that our therapy providers are doing the same. Progress reporting. The following 4 components of progress reporting will be discussed in the next slides. These include whether the goals were met, what relevant barriers were reported for those goals or treatment plans not met, What, if any, modifications were made to the treatment plan during the last authorization period? And lastly, reviewing the goals that were unmet and how much progress has been made towards those goals. Progress reporting continued. This information is directly from the prior auth therapy policy. It states, as the treating therapist has set the treatment goals for a specified time period, it would be expected that short and long-term goals would be met within the specified time frame. If the treatment goals are unmet, it is the treating therapist's responsibility to objectively describe any barriers to progress that were encountered. Any modifications to the treatment plan must be reported, described, when and why they occurred, and what is the progress towards those new goals. We are looking for those barriers that are out of the control of the therapist. For example, the member was sick, so how many visits were planned for and scheduled as compared to how many they attended? Maybe they only attended half of their planned sessions. Then explain this in relation to progress. Or maybe they were hospitalized during the treatment period and then resumed treatment thereafter. Again, explain the timeline in the documentation. Or for our foster care members, the child had a change in placement, which can significantly impact their status and ability to make functional gains. Offer the dates and the member's behaviors, affect, etc., and the plan to support them via other consultative services. With all of those examples, what still is in the control of the therapist is the treatment plan. So we should also be seeing modifications to the treatment plan as able during the last treatment period in order to reflect what best met their needs. Treatment plan modification. Are the goals still achievable? Monitoring the plan via rate of progress. The clinician needs to be monitoring the client's progress throughout the treatment period and not only at the end when requesting additional visits. Changes to the treatment plan need to be made timely. Therefore, knowing where the client is in relation to the goal is important throughout the entire treatment period. Deciding to modify. When? What are the new goals? What is the progress towards those new goals? Be sure to document this information, especially the date and type of modifications that were made. Are the assistants notifying the therapist of needs? When applicable, the assistant and licensed clinician's communication is very important so that the licensed therapist can make the necessary changes for the assistant to treat towards. The treatment plan may be modified at any time, possibly more than once. The timeline and related updates or changes must be documented and clear for progress determination. The need for an MD signature on a modified treatment plan is facility specific. Many times we hear from therapists who state, "We didn't know we could modify the goals." This is concerning as this is within the scope of practice for all three disciplines and is an expectation within each to adjust the goals and plan in order to best meet the needs of the client. Goals are not static and we need to modify, sometimes several times. If it is your employer's policy to obtain an MD signature on any updated treatment plans, then do so and continue to treat the patient. However, do not put the patient on hold as this in itself can impact progress. It is within our scope of practice to make alterations to the goals. Putting a patient on hold while waiting for a doctor's signature is not a relevant reason for lack of progress. Let's dissect this a bit more. In the case that the targets of the goals are being reduced, or the therapist is changing the skill being addressed to a lower level, this would not require an MD signature by Superior. However, there are times that a new treatment diagnosis is revealed during diagnostic treatment, where a signature would be important in order to communicate to that referring doctor about a new problem. An example may include the member was being treated for communication-based goals, yet a swallowing issue has revealed itself. Maybe this was not initially evident or known. We would expect the SLP to continue to treat the original treatment plan while they await the MD signature, again, if their employer should require it. In any case, if you are in the midst of a treatment authorization and see the need to alter your goals, then rewrite them, treat towards them, and then include that documentation when you submit for any additional therapy once your authorization is completed. You would not need to submit any changes to your goals during the middle of your treatment auth. Continue to treat and document what took place upon the next request. Progress reporting continued. Although the expectation is for the goals to be met and/or modified in order to be met, there are many times when the goals are still appropriately set, yet the member has nearly met them. Maybe another few sessions and they would have been met. This is why we like to give the therapist the benefit of the doubt and determine how close the member is to meeting the goals the therapist has set for them. This slide states the need for documentation of objective demonstration of the member's progress towards each treatment goal. In this context, objective is data that can be calculated. For all unmet treatment goals, the baseline and current function must be submitted so that the member's progress towards those goals may be measured. The targets and variables reported on must be in the same terms as the targets and variables within the goal. Be sure to document the baseline and current status as the targets are written. If the target is written as, for example, the patient will verbalize a one-word utterance in 70% of opportunities, then do not document how they did imitating a one-word utterance or how they verbalize a two-word utterance. The therapist should be treating towards the targets and the goals and reporting on the progress towards those targets. If you find you needed to alter what and how you were treating, then the goals should have been modified and rewritten to reflect such changes. Let's define baseline, which is where the client was functioning at the beginning of the last auth period. For example, if the last treatment plan was for 6 months, then document the member's status towards the goals targets at the beginning of that last 6 months. Progress is a review of the last auth period. Please be mindful not to include the baseline of a skill from a previous time period, as that may inflate the progress and not accurately reflect it. When reporting on goals with multiple variables or measurements, it is the reviewer's assumption that all variables are a constant and only one measurement is being reported on. For example, patient will don t-shirt with minimal assistance in 3 out of 5 opportunities while seated. Be sure to indicate which of these variables is being measured and reported. Is the focus on reducing the assist level? Is the focus on increasing consistency, so focusing on the number of opportunities? One may assume it is the assist level, therefore all other variables would be considered a constant. Be mindful that you are reporting on and how you are reporting it so that it reflects the progress towards the goals. Doing so will best show the effectiveness of the treatment that just took place, not only for the clinical reviewer, but most importantly for you as the treating therapist. Keep in mind, when documenting, if it is not documented, it did not happen. How many times have we heard this in our practice? If it is not documented, there's no way to validate it took place. This is the same for your Medicaid patients. There are limited assumptions on the part of the clinical reviewer. There are 30-plus therapists across PT, OT, and SLP who review the prior auth therapy requests for Superior HealthPlan. They are specifically hired in order to offer our providers a skilled review by someone who speaks the same language. Yet they have limitations with their assumptions in that they are held to adhere to the policy and validate the clinical documentation criteria by showing the evidence from the clinical documentation itself. Follow clinical practice guidelines for the treatment diagnosis as well as evidence-based practice. Meet the patient where they are. Set the goals for the time you requested, not what you see them doing 1 year from now. Paint the picture, tell the story. It is a balance of writing concisely, yet inclusive of relevant clinical information within the documentation. We can be an outstanding clinician and not necessarily capture all necessary clinical information in our documentation. Assessment and our treatment skills are different skill sets from writing skills, so be aware if this is an area to improve upon, as reviewers are relying on what is actually documented. A few last remarks before concluding this presentation. An important reminder for PTs, OTs, and SLPs to keep in mind is we only know about our members' functioning through the documentation that is submitted for review. Clinical determinations are based on the information within the documentation. Therefore, a denial is not of the member getting therapy. Rather, a denial of an authorization is based on the documentation we had for review. the member can still pursue the treatment through various means, including an appeal of the denial or circling back to the referring doctor to determine the next steps. One of those steps may include a referral to a new therapy provider. If Superior is not able to authorize the request, always appeal, as the appeal process allows more time for the therapist to offer additional clinical information. Either the member, the therapist, or the referring doctor can make the appeal request. That concludes this presentation. Again, my name is Heather Albers, and here is my contact information on this last slide. Please reach out if you should have any prior auth or appeal clinical documentation questions in the future. Thank you.